Good morning, everybody. Thank you for joining our ISSUP South Africa webinar. This is session 2, and we welcome all of our new members and those possible new members. Please feel free to log on to ISSUP South Africa website to find out more information about who the ISSUP South Africa is. We are the International Society of Substance Use Professionals, and at the moment we are looking at bringing together the substance use professionals throughout the country. So feel free to join us as a member. At the moment, membership is absolutely free, and we look forward to welcoming you. We also welcome our presenter, Siphokazi Dada, and for those of you who weren't in the first session, please just feel free to ask any questions by posting the questions in the question panel on the second in your dashboard, and we will have a short question and answer period on the ISSUP's website, and all the presentations hopefully will be able to be posted on our website as well at the end of the presentation. So to introduce Siphokazi, and thank you so much for agreeing to do this, Siphokazi. Siphokazi Dada is the senior scientist in the Alcohol, Tobacco and Other Drug Research Unit of the South African Medical Research Council, otherwise known as SACENDU. She has a Master of Public Health degree from the University of London. She is currently registered a PhD student at the University of Stellenbosch, and her area of interest is misuse of over-the-counter and prescription medications, particularly focusing on codeine. She also manages the South African Community Epidemiology Network on Drug Use, which is SACENDU, a drug trends monitoring system operational throughout South Africa's 9 provinces. And very interesting was something I didn't know about Miss Dada, and it's very it's great to hear this. She is also a Marie Curie Fellow on the CODEMISUSED Project funded by the European Union. So we're very proud and grateful that you've agreed to give us your time, Siphokazi. So thank you very much. I'll hand over to you.
Thank you, Roger. Thank you so much. Good morning, everyone. So I'm grateful for this opportunity. And this morning, I'll be talking to you about cannabis use among South African youth. And I'm just going to look briefly on data, on treatment admissions before the Constitutional Court of South Africa decriminalized cannabis use, and data after. So I'm going to look at 3 periods. The data from 2017, 2018, that was before the Concord ruled on the decriminalization of cannabis use, and then look at 2019 data to see if there has been any increase or any changes in treatment demand for cannabis related problems. So we know that the use of sorry, I just need to. We know the use of coactive substance by youth globally in South Africa is a big problem, particularly because it gives a chance to young people to increase access to legal and illegal substances, and they also are more likely to experiment with new drugs that are coming into the market, and then it can also result in unintentional injuries and other problems. Tobacco, alcohol, and cannabis are the substances that are mostly commonly used by youth in South Africa. And these substances are the risk factors for violence and crime, injury, and other social problems. The use of these substances is also associated with high sexual risk behaviors and earlier initiation of sex and scholarship problems. So youngsters are tend to be absent at school or to drop out of school, and also included in these are mental and physical health problems that they experience through using these substances. So how do we define, or how is youth defined globally? Globally, the definition of youth globally varies, and also in South Africa, it also varies based on the context that which is used. The United Nations refers to youth, to young people between the ages of 15 to 24 years as youth, while in South Africa, our South African Youth Commission Act defines youth as people who are between the ages of 14 and 35 years old. So according to the recent data from Statistics South Africa, in South Africa, youth constitute a third of the population. So we have about, up to 2019, mid-year 2019, the South African population is about 58 million, 58.8 million, and 20.3 million of those people is the youth, so those between the ages of 14 to 35. Although the youth constitutes majority of the population in South Africa, they are faced with numerous challenges such as substance use problems, mental health problems, sexual risk, and other problem behaviors. So, and these challenges are compounded by structural factors, including high level of poverty, unemployment, social inequalities, inadequate access to healthcare, social, psychosocial, and other educational services. So in terms of substance use in South Africa, despite these challenges or this considerable health and social impact associated with substance use, we do not have regular representative surveys, household surveys on substance use in South Africa. Those that have been conducted are outdated, or the data is not current. We don't have current estimates of substance use in general in South Africa. One of the surveys that looked at youth was conducted it was last conducted in 2011, and then the other study that also looked at young people was also conducted in 2012.
Okay,
what that study, the 2012 population, 4.4% of the people in that survey reported any drug use. So they measured current use in the past 3 months. So 4.4 of the people in the study have reported any drug use in the past 3 months. And then when you look at further at those drugs, which drugs that they were used, 4% reported cannabis use, and then amongst those who reported cannabis use, 2.8% were between the ages of 15. Sorry, it should have been 14 to 35. So that is our youth. So the only consistent data that we have that looks at substance use frequently or every 6 months, reports every 6 months, comes from the SACENDU surveillance system, which monitors alcohol and other drug use trends in South Africa. However, it also has its own challenges or its own limitations. We'll talk about that later. So in September 2018, the South African Constitutional Court decriminalized cannabis, the use of cannabis in a private space. And then there was a draft that was developed in response to this Constitutional Court judgment. However, Parliament was given 24 months from that date of judgment to bring this into the South African laws. So we are waiting to hear from September 2020 what will be the final bill or the final law regarding the criminalization of cannabis in South Africa. So at the moment, the bill, which is not necessarily released publicly, is that South Africans will be allowed to possess up to 600 grams of dried cannabis to use in privacy of their homes. Even though people can use cannabis privately, however, buying and selling of cannabis or cannabis oils or cannabis seeds still remain illegal. And so people cannot sell the cannabis for recreational use or for medicinal use. So the purpose of this presentation, or of what I'm looking at, is to describe changes in treatment admissions for cannabis-related problems in South Africa among youth, looking at data before and after decriminalization. So I'll be using the SACENDU data, which is the treatment data. So what is SACENDU surveillance system? It's a surveillance system that provides community-level public health information on substance use-related trends in South Africa. It's operational in 9 provinces of South Africa, and it collects data from substance use treatment centers, which participates voluntarily into the SACENDU system. And then those treatment centers that are on our system, at least we feel they represent about 85% of all treatment centers available in South Africa. We do keep recruiting treatment centers to join the network because this is the only surveillance system in South Africa we have that monitors, that can tell us if there has been any increase in substance use, particularly amongst people who are entering treatment or accessing substance use treatment. So in order for a person to be admitted into the treatment center, the patients have to meet the diagnostic criteria for alcohol and other drug use disorders. And then when they get into the treatment center, a standardized 2-page data collection form is completed by a case manager. So treatment centers that have access to internet, they complete this electronically. Treatment centers that do not have access to internet, we provide paper forms of the form. And then they complete these for each and every 6 months. And for each patient that come into treatment and enters or is enrolled into their treatment program. Every 6 months, we analyze the data and then we see the trends of what is happening per province. The form consists of 22 first questions that the patients can respond to. So some of these questions are just socio-demographic, socio-demographic variables, type of referral sources, type of treatment that the patient has received. Maybe the patient has accessed inpatient or outpatient. What are the primary substance and secondary substance that they are presenting with into the treatment? How often and how frequent, or how do they take their substances? That's mode and frequency. Have they been to treatment prior, treatment experience, and who's paying for their treatment? To ensure data quality, completed forms are checked for possible miscodes, and missing information data is looked at, and information that is missing before the data analysis is conducted. So the SACENDU surveillance system project is approved by the Stellenbosch University Health Ethics Committee. Today, what I did, the analysis I did, just descriptive analysis, looking at those figures, any changes. So I did secondary analysis to the data analysis that we have, and data was used to do this analysis. And basically, the youth or young people between the ages of 14 to 35 make up to 75% of annual treatment admissions. So looking at 2017, 2018, that was pre-decriminalization, and then post is 2019. Unfortunately, the 2020 data is not available yet because we're only 6 months behind. So hopefully in the future, I will share that information going forward. So what this tells us, basically, the majority of people in treatment, of young people in treatment, are males. About between 16 and 17% would be females. The majority are also Black African patients, and I must emphasize that this does not mean that other people do not use substances. Remember, these are the people who are accessing treatment in South Africa for their substance use. But again, the majority of our population in South Africa, if you look at the census data, tells us that up to 75 or so 9% of the population is Black African people. In terms of education, the majority of those people who come into treatment have at least high school, between grade 8 and grade 12. In terms of employment, I'm looking across the 3 years, it still continues to show that the majority, up to nearly half, or actually up to half of those people in treatment are not employed, and then about over a quarter of young people are still at school that are in treatment. In terms of the treatment type that they have access, the majority of young people access outpatient services compared to inpatient services. And those inpatient services include private treatment centers that need funding from the medical aid, but mostly they are outpatient services that young people are accessing as well. So we ask the patients also if they have been to treatment before coming into their treatment this time when they come into treatment. So the majority would have reported that no, it is their first time to come into treatment. And then about 15%, 15 to 18% would report that they have been to treatment for substance use problems before. And it does not necessarily mean to this same treatment that they've come to, but to any other treatment that they have been in their lifetime. So who pays for treatment when people go for substance-related problems? So the state seems to be funding a lot or footing a lot of the bill, but we do have about 22% of patients whose treatment is paid by family and friends, and then the medical aid is paying between 8 and 11% of treatment services. So what substances do these young people present with in treatment center? Throughout these 3 periods, we can see that young people are more likely to report cannabis as their primary substance of use. So this is the first drug that they tend to use, or at least at this moment, they have a problem with, and they have come to seek help for. And then if you look, then the second primary substance is reported is heroin, which is very interesting at this moment because in the previous studies, we've seen that the most common substances that are reported among with youth is cannabis, alcohol, and tobacco. We did measure tobacco we do measure tobacco in the form, but chances are 99% of the persons in the treatment centers are also more likely to report tobacco use. So methamphetamine as well is the fourth, comes after alcohol use, reported as the primary substance of use that is reported by youth. And then there is nyaope, which is a cheap form of heroin, which youngsters mix it with so many things, but primarily it is heroin and cannabis. And then they mix other substances. And then in different towns or different provinces, it's called in different names. So in Gauteng, for example, it's called nyaope or wunga. Durban is called wunga. So that is also coming up from youth reporting that as their primary substance of use. And if we look at the trends, or between 2017 and 2019, it has increased. The number of young people reporting nyaope as the primary substance has increased from 4% to about 11% by the end of 2019. Cannabis use, 40% has been reported in 2017, decreased to 35% in 2018, and further decreased also in 2019. So what we think is happening there is that cannabis, it's cheap than maybe heroin, for example, but now the youngsters have an option of this nyaope, which is even cheaper, that they can buy. So maybe they are switching, or they no longer maybe use it or present it as a primary substance. They're more likely to present the nyaope as the primary substance when they get to treatment. So how frequent do these people who reported cannabis, how frequent do they use it? The majority of youngsters have reported it, that they use it every day, daily, and this is consistent throughout the 3 periods. And then about 25 to 6% reported to be using it 2 to 6 times a day, once a day, about 10%. And then there are those who come into treatment who have used it, or who have not used the drug in the past month, but they are seeking help for their cannabis-related problems. So we know that people in general, people who use substances, and especially youngsters who are more likely to experiment, they don't use one drug. So they're also more likely to use more than one substance, taking another one as an upper and then another one as a downer. So again, cannabis still stands out as the secondary substance that is reported by the youth. And then in this, as a secondary substance, it seems to be increasing. There was about 25% of youth who reported it as a secondary substance in 2017. And by the end of 2019, about 28% have reported it as the secondary substance of use. If we can look at Menrex, we see that it was not used or reported primarily as a primary substance of use, but it shows up as a secondary substance of use. So it means that it is another drug that the youth are taking as a secondary substance of use. So because it shows from about 13% in 2017 to about 16% of the youth reporting Menrex as the second substance of use. Methamphetamine is also seen there as well. It's quite predominant as a secondary substance of use. And then this nyaope, the proportions of nyaope or yunga as a substance of your secondary substance have decreased, or at least these proportions are lower compared to it being reported as the primary substance of use. So in terms of summarizing the findings, we do see that cannabis is still the most commonly reported primary substance of use by the youth. Although if we look at between the 2017 to 2019 pre-discrimination and after decriminalization of cannabis, we can see that we don't observe any changes per se, any significant changes. Yes, it has decreased, but these are not necessarily significant. However, there is a slight increase of nyaope as a primary substance of use, as I mentioned, which may suggest that the youth might be changing between the two drugs due to availability and the price. Heroin, alcohol, and methamphetamine are also reported as the primary substances of use by the youth, other than cannabis, and then Menrex was more prevalent as a secondary substance of use. Unfortunately, the majority of patients who come into treatment, it's males. I'm saying unfortunately because we're not seeing much or a lot of women, which we think there is use of substances amongst women, but there are so many challenges that put women, or that make women not to be able to access treatment. For example, having young kids that they have to look after, the fear of admitting to substance use, that their children will be taken away. So these are the challenges that are more likely to make less women to come into treatment. And the majority of our patients are not employed, which is very sad for our youth. Definitely, the SACENDU data or the surveillance system has its own limitations. firstly, the data is collected only from treatment centers that voluntarily participate in the SACENDU system and that are consistent in submitting data. And therefore, unfortunately, because this is treatment data, it's not telling us much about substance use in general population amongst the youth. So given the limited availability of services, the number of patients recorded is likely to be an underestimation of the actual numbers of young people that are using substances in the population. Our system does not collect identifying information, for example, an ID number of each patient, but so there's no identifying information, and therefore we are not able to control double counting. So, and we know patients are more likely to attend treatment over and over. So this also may slightly inflate our numbers of the number of people receiving treatment, and it has biased the data towards those who only seek treatment across more than one treatment. In conclusion, we do see that these findings do show a decrease in treatment demand for substance use, particularly for cannabis, among people looking at those numbers. However, I mean, it's still early days to measure to measure post decriminalization of cannabis. We think we just need to keep monitoring these treatment demands, and then we can see further on, maybe from 3 years later or 5 years, we can see a different trend or a different graph in terms of cannabis treatment demand and cannabis use in general in South Africa. So we do need to keep monitoring these cannabis use proportions. However, we also do need regular representative household surveys on substance use in general in South Africa and substance use among the youth, so that we can have proper estimated numbers and prevalence that we can compare, or we can be confident to say what is the prevalence of substance use in South Africa. Thank you very much. I hope I was clear and I made sense. Thank you so much.
Thank you, Siphokazi. Thank you very, very much for that presentation. Do you have time for one question?
Yes, sir.
Okay, thank you. And thank you to Devin DeCocker for posing this question. He asks, do you think the decriminalization of the private use of cannabis in 2018 aggravated cannabis use by the youth and its development into substance use disorder?
I do think that may lead to more young people using the cannabis use. Again, the challenge now, like I mentioned with this law, is who is going to monitor how much people are using, and if they're really using at home and do not go into the street, or do not even tend to go into other substances. As the youth, we know it tends to experiment with many other substances. So this is worrying indeed, that it might increase use among the youth, but we'll have to see. But it is important then not to just decriminalize it and allow people to use it at private homes. What are then programs or interventions then that have been put in place in case we are experiencing the increase? Because we're definitely going to see an increase in substance use among young people in cannabis use. So I think it is also important to inform policies, or at least the government, to put interventions in place for those people.
Hmm. Thank you. And then a further question that was asked by Nikki Retief is, do you think the decriminalization of cannabis might have led to less youth seeking treatment for this as a primary substance?
That is also possible. That is very much possible, because now the youngsters can say, well, it is allowed. It's no longer seen as an illicit drug, so they may use, because they would use it recreationally and use it among friends, and then they would probably not see any need to seek help. I feel that we might end up being in that mindset of over-the-counter prescription medications, where people who misuse those drugs do not recognize themselves or do not put themselves with heroin users, for example. They do not call themselves addicts. So we're facing a very different, a very difficult situation. I do think that young people may be less likely to come forward for cannabis use related problems in the future, because they will feel and they will say it is legal now.
Thank you. That appears to be our questions asked. If anyone does have any more questions, please feel free. Okay, sorry, there is one just come through. What are the implications for treatment centers regarding the Dada ruling?
Yeah, I think the implications for treatment centers is to they need to prepare themselves for more young people that may come forward, or we know that the more people use, or at least now that it is legalized, people may feel that they are freely to use it. So they must prepare for those that will be more likely to say, I've used it, it's not working for me, I would like assistance to get off it, or at least to reduce my use. So treatment centers have also to be prepared for inflation of young people coming into treatment in the near future.
Okay, and then our final question, and apologies to those who I haven't had a chance to get to, but we will post these questions on our ISSUP website and ask Siphokazi to respond to them there. The final question I'm going to pose to you, Siphokazi, if you don't mind.
That's fine, Roger.
Do you think the restriction on the sale of tobacco products will increase the use of cannabis?
I don't know. Chances I can. I guess because people, it's accessible. I guess it is the accessible thing to them right now. So they may switch to cannabis use, which is very scary, because now they're moving into another addictive substance. I mean, tobacco is also addictive, but now people may be desperate in these desperate times and may use what is available to them. And if cannabis is available to them, they would need to turn to that in order to deal with their craving.
Okay, all right. Thank you very, very much. And for those of you who we haven't had a chance to get to questions, there is a very pertinent question here, Siphokazi, if you don't mind. I think one of the biggest difficulties that we as substance use professionals are dealing with in the country at the moment is the implications of the Dada ruling on the workplace. And how do the companies deal with the testing for cannabis? I mean, we all are aware that cannabis remains in the system for a period of time, you know, and this is possibly something that we as ISSUP would look at in the future, posting, having a webinar around this and getting some sort of legal response to it. But how could companies deal with the testing for cannabis?
I don't know, honestly. But the other interesting thing is, do companies regularly test for substances? Because I think the most substance that companies would test for is alcohol use. So I think it would be important to start testing for other drugs as well, especially now that people would be more likely to use cannabis. But at the same time, what then do you do if you find someone who comes to work and intoxicated or has used cannabis, and they can defend themselves and say, but I didn't use at work, I used at home, but I also needed to be in the office. So it's going to be a challenging it's going to be a challenge indeed. So I think such things need to be put in place, and so that companies can know how to deal with substance use in general at work, but more likely now with cannabis use that is legalized or decriminalized.
Okay, thank you. That's very interesting. And again, I think it's something that a lot of the questions coming through are looking at what are the rights involved with children using cannabis and that kind of thing. And I think that that's something that ISSUP South Africa can look at going forward, and possibly look at our next webinar, looking at the legal implications relating to the decriminalization of cannabis use, and how it relates to workplace environment and how it relates to children's rights, that kind of thing. So thank you to all of those questions posted. It's not that we are ignoring them, but there is one final question that has come through here that I think is extremely interesting, and I'm going to pose it as the last question, Siphokazi. It is Vatiswa asks, it is interesting to see that the drug use trends have changed amongst youth, the primary use and the secondary use. What are the reasons for the change in trends?
Of course, one, access to, okay, we know that at least youth forms about 75% of the treatment population, so at least they're more likely to access treatment. But in terms of change, like I said, youth, they tend to use, to try many substances. Yes, there are those when they probably would say when they reach, let's say, age 25 to 35, then they're more likely to stick into one substance, or at least they have their primary substance of use. But you've got that small proportion that is experimenting with substances, that keeps changing. And you must also remember, especially with alcohol use, alcohol dependency takes time, and we think that, yes, young people tend to present into treatment centers for alcohol-related problems, but chances are they've been binging and they've been found at home or busted at school, and therefore are sent to treatment, or the court has sent them to treatment. But in terms of dependence for alcohol, it takes time. The mean age of a person who has dependency on alcohol is about 38. So youngsters tend to go up and down in experimenting with substances. So I think that's one of the reasons that may change. You may see an increase in cannabis use this year, but you can see an increase in heroin the other year. But you must also remember, because they also on the background checking new substances, and they want to try substances. So we also monitor new substances that they are coming. And because youth wants to fit in, young people want to fit in, so they would try any other substances that would come in the field. And therefore that could be another reason then that would make fluctuations in terms of young people accessing treatment for different substances.
Thank you. Well, Siphokazi, thank you so much for your input. It was really, really fantastic having you with us, and we look forward to having you again give us more about that. For those of you who are still in the room and are not linked with the SACENDU unit, I have posted in the chat frame contact details for SACENDU. What SACENDU is trying to do is trying to establish a network of clinics that we can draw proper statistics from. So if your clinic is not involved in the SACENDU research project, please contact them directly, because we need to get more of an understanding of what is going on in South Africa. And so please feel free to contact them and join the network so that we can have a proper statistics developed on an ongoing basis in our country. And again, thank you, Siphokazi, for taking your time out. I know that you're extremely busy and that you've pushed aside a meeting just to be able to do this for us. We really do appreciate it, and we look forward to having more of your insights going forward. So thank you very, very much. And thank you once again for your support of ISSUP South Africa and all that you have done.
Thank you, Roger.
It's a pleasure.
Thank you.
To those of you who I didn't get to answer the questions, I have taken a copy of all the questions, and we will post them on our ISSUP website. Again, please feel free to make, or please ensure that you have joined our ISSUP network by going onto ISSUP, the ISSUP website and joining South Africa. We will endeavour within the next couple of days to make available all the presentations that were presented today, and the videos, the link to the videos that will be posted on ISSUP Global's YouTube channel going forward over the next couple of days. So please keep an eye open for that, and thank you so much. And we will keep you informed about our next webinar, which we hope to have a webinar possibly the end of July again. And I think from what I'm seeing in the questions that are posed today, the most important question that has come up is focusing on the legalese around cannabis use and the decriminalization of cannabis in South Africa. So I think that is something that ISSUP South Africa is definitely will look at going forward. And yeah, so thank you for all of that. Great, and that will wrap up our second session, and thank you so much again to all the attendees for joining us today. I hope you got something out of both sessions. Really, really grateful that you could join us, and we hope to see you again. So thank you very, very much.